Meanwhile, Dr. Sathesh, please start.
Good afternoon, everyone. Today I am going to present a rare ocular presentation of bilateral megalocornea and high intraocular pressure in a Treacher-Collins syndrome. Overview of Treacher-Collins syndrome. It is a rare autosomal dominant condition primarily affecting the first brachial arch structure, that is eyes, ears, and facial bones. It affects about 1 in 50,000 live births. It primarily presents with craniofacial features, and ocular features include lower lid coloboma, antimongoloid slant of palpebral fissure, canthal dystopia, ectropion, dermoids, and high astigmatism. Coming to my case, it's a 6-month-old baby diagnosed with Treacher-Collins syndrome, referred by a pediatrician for ophthalmology assessment to a tertiary eye care center. The mother was concerned about notched eyelids and downward slanting of both eyes of the baby since birth. Coming to the birth history, it was a full-term baby delivered by elective LSCS to a non-consanguineous marriage. And the pedigree chart of the 3 generation confirmed the sporadic nature, and systemic examination were within the normal limits except for the features of Treacher-Collins syndrome, that is lid coloboma, downward slanting of palpebral fissure, micrognathia. And the baby was able to fix and follow the light, and the intraocular pressure in the right eye it was 22 mm of mercury, and in the left eye it was 26 mm of mercury, measured by using a rebound tonometer. Coming to the anterior segment examination, the right eye lower lid showed a defect of 2 cross 1 mm near the lateral canthus with loss of eyelashes, with megalocornea and prominent globe and prominent nose with antimongoloid slant. The similar findings were noticed in the left eye along with lag of thalmus. In the first picture, you can see the hypoplasia of the zygomatic bone, hypertelorism, antimongoloid slant, and micrognathia. In the second and third picture, you can clearly see the lower lid coloboma with loss of eyelashes. There is no evidence of HAP striae or ophthalmus, and we have started the patient on dorzolamide eye drops in both the eyes. And we have planned examination and anesthesia after a week, and we confirmed the megalocornea with a corneal diameter of 12.5 cross 12 mm in both the eyes, with a deep anterior chamber depth of 3.41 mm in the left eye. Apart from that, the intraocular pressure, axial length, fundus, optic nerve head, and foveal reflex were normal. Coming to the systemic and genetic investigation, there was a small atrial septal defect and mild pelvic-calcial system separation is noted in the left kidney. And the cytogenetics confirmed the male karyotype, and genetic analysis showed heterozygous mutation, the TCOF1 gene, suggestive of Treacher-Collins syndrome. And my diagnosis is Treacher-Collins syndrome with bilateral coloboma of the lower eyelid with megalocornea. And we have started on dorzolamide 2% eye drops twice a day in both eyes in order to prevent the infantile glaucoma, and conservatively treated to prevent the exposure keratopathy. Coming to the discussion, more than 60% of Treacher-Collins syndrome were sporadic, and according to Franchetti and Klein classification, it is further subdivided into 5 types, that is complete, incomplete, abortive, unilateral, and typical. I will categorize my patient under typical form. So the take-home message, megalocornea is not commonly associated with Treacher-Collins syndrome. To the best of my knowledge, only one case was reported so far. And megalocornea with high intraocular pressure is not a definitive sign of congenital glaucoma unless ophthalmus and other signs are present. Careful evaluation is needed to avoid misdiagnosis and unnecessary aggressive intervention. Follow-up is important to monitor for glaucoma development in future. And a multidisciplinary approach involving ophthalmologist, pediatrician, radiologist is essential for optimal care and early intervention, especially for parental counseling. This case emphasizes the importance of refining diagnostic criteria and treatment strategies for syndromes with atypical presentation. These are all my references. Thank you.
Okay, thank you. So it's a very rare condition.
Rare.
One thing is that you can go for the IO case publication for this.
Yes.
You have all the documentation, plan it and write it in a proper way and submit to the IO case reports.
Sure, sir.
Wishing you good luck for that.
Thank you, sir.